Boa noite, amigos
Good evening, friends.
musculoesqueléticos.
Friends
Grande
from
prazer
the
encontrar
musculoskeletal tumors. It's such a pleasure to meet you in the seminar. This is a program of continuous education of the Brazilian Association of Orthopedic Oncology. And today we're having the third webinar of this program of continued education. Our sponsors, I'd like to thank them, Paulo, Implantcast. We also have the support of the Brazilian Society of Pathology and Brazilian Society of Clinical Oncology. I'd like to thank the managing that it's of Acontece and everybody that is making this event possible, the organization of Dr. Ricardo Becker. Today, we're going to have three presentations that are very interesting. The first one is about the giant cells, tumors of bones in giant cells, and the second one about the prophylactic antibiotic regimens in tumor surgery of bone sarcomas. And the third one is the challenge of the complications of endoprostheses. So great event for everybody. Ricardo Becker, the floor is yours. Good evening, everybody. Good evening, everybody that is participating on this webinar. I'd like to call our dear friend, Dr. Felipe, which is a clinical oncologist. He's a collaborator of Recife, and then he's been helping us so much. And it's a routine already in the clinical treatment for musculoskeletal patients. So, Dr. Felipe, you can please start your presentation about systemic treatment of giant cells bone tumor of bones. I'd like to thank you so much, Ricardo, and everybody on behalf of the Brazilian Society. And it's so good. It's so great to talk about the musculoskeletal problems. Ricardo asked me to talk about the giant cells tumors of bone. In Recife, we have that happening a lot because we started developing a protocol, and in my vision, it actually was beneficial for a lot of people. So here I don't have there's no conflict of interest involved in this class. Well, the first thing, it's a very rare tumor. There is a rarity already for bone tumors, but when we speak about giant cells tumors, we're speaking about only 5% of those. It actually prefers the female genre, and especially young adults that are in their second or third decade of their lives. This tumor has as a characteristic, it's very radical and it's much more local, but even though it's more local, it can become malign and actually goes into metastasis, I'm sorry, when we talk about coming back. Well, the tumors, they can have a relapse, and they have a radiological classification, and it depends on the classification of the bone classification. 1 is involved by the bone, and 3 when you have an extravasation of when you have a rupture of the bone and it goes to the soft parts. Even though the name is tumors of giant cells, this component of giant cells is not the neoplastic one. The stromas that are rich of mononuclear cells that act in many, there are many signalizers that actually jeopardize or impair, better saying, the normal bone metabolism, and it brings the malignity of this type of tumor. And as we understand this physiopathology, made us think about a treatment for these tumors. So they're very related to this metabolism of bone remodelation. We have an interruption or some sort of alteration of the mechanism. And this alteration of the mechanism will take to some sort of hyper work of the osteoclasts to do. So then we see the injuries of these tumors for giant cells that are very characteristic, as we saw in that picture. And then not too long ago, this was not considered as a tumor, but as we understood more molecular biology and genetics and studying genetics of these tumors, we noticed that the alteration of the telomerase activities, the amplifications of centrosomes, and especially the mutations P53, actually really classified that tumor or this entity as a tumor. And up to recently, this tumor was seen as a benign, but in the last classification, it changed to an intermediate locally aggressive, but rarely metastasizing to other places or locals. But since we're speaking about a tumor that is locally aggressive, well, and there is a possibility for treatment, but the metastasis is rare in this type of tumor. So, I'm sorry, metastasis. So the main complaints of the patients is pain and edema, but the pain actually make them limited. They are impaired. They can't move very well, the patients. It's usually around the knee, especially distal femur and proximal tibia, as I said, and it can be very impairing and very bothersome. When we speak about treatment, we have to talk about the possibility of treating. The ideal, of course, we want to make it less morbid and avoiding the relapse of the disease. But the relapse can get to 50% depending on the type of treatment. We know already that the patients that have more radical approaches with surgeries in monoblock, they have less chance for relapse, maybe 10 to 15%, but the intralesional or intralesional approaches there are other approaches that can help the recurrence of this type of tumors. As I said, the recurrence will vary according to the type of surgical approach that the doctor will choose. And why should we treat this systemically, a tumor of giant cell? We understand the biological rationale or reasoning, and we try to work in having a medication or a drug that can actually act directly in that. We're speaking about young adults. Some surgeries that are more radical, especially with prostheses and so on, I mean, the functional results are good, but the situation is that there is a big possibility, a real possibility of these prostheses be revisited. We're speaking about a young adult of 20 or 25 years old, and this revisiting can be many, and then the morbidity can be worse. Of course, we're trying to avoid the recurrence and also the metastatic disease. Well, this situation of a tumor that is intermediately not too strong, we need to modify the surgical treatment, improve the symptoms, reduce recurrence, and avoid, of course, the metastatic disease. maybe 5 or 4 years ago, the only treatment, common treatment, was the surgical treatment. Other treatments, they had some sort of action, some sort of outcomes, not such good outcomes as they expected. And bringing all the reasoning, when we talk about the physiopathology of the disease, they thought, doctors thought, physicians thought about one a mechanism of action of denosumab. And in this reasoning, well, this rationale was actually proved in many studies, and I bring actually a data from us here in Recife. We presented, as a matter of fact, in the last Congress, medical Congress of ASPES last year, that the patients that used denosumab previously of any surgical treatment, we had at least 63% of a complete pathological response in biopsy. We did not find tumoral components after the surgical treatment with patients that used denosumab. Of course, we had patients that previously showed that rationale of those goals that we had before. So this study, this trial is already phase 2. It's a phase 2 trial that used denosumab in patients with giant cell tumor of bone. They have indication for prostheses, and 96% and 86% had a resection of that. And this chart is very good to illustrate when we think about a surgery that is planned already. See, surgery that was planned in this column and the surgery that was actually done in that line. We see a big majority of the patients that were not submitted to planned surgery. The number of patients that didn't have surgery was probably 50% actually of the patients studied. But if we saw the patients that were submitted to surgery and the surgery was less morbid, the number was big. Only 26 patients were submitted to a surgery that was previously planned, and 6 had a surgery which was more morbid. Another phase 2 study or trial, they saw some patients that had a possibility for joint resection, and the patients that were supposed to have bigger surgeries, I mean, the surgery was much less morbid actually, because the surgery was changed for less morbid or no surgery at all. This is a evaluation with, less patients, a small number of patients that they had relapse. 20 patients had giant cell tumors, and they underwent surgery. And this was the first work that showed a patient that could be worked as intralesional. We preserved the articulation, the joints in 18 cases, and the recurrence was about 15% when we have a more radical type of surgical treatments. And this yet is another data that actually got more than almost 200 patients, 112 patients. This 112 patients, 89 were submitted to a treatment with the drug denosumab, and 100% had an indication for surgical treatment, more radical. And when we evaluate, when we see the post-denosumab treatment, we saved 50% of those people that had the surgeries. The recurrence was not too low when we compared the patients that had patients had some events. Only 7% of the patients had that. Well, there were other benefits with denosumab. We saw a line related to time, patients that feel pain, and the improvement is much better in these patients. Patients that had some difficulties, impairments to walk, And in the next month, we saw them not even taking any more medication for pain. The same way that we have works showing low relapse, we have many works that show more recurrence. And this is one of those patients that had, there was only one institution. This patient had a tax of a level of recurrence of 49%, 44%, the ones that used denosumab, and the ones had no recurrence after resection. The Constantino Errani group, they evaluated patients that had patients pre-surgery using denosumab, and they compared that. The only data that they had with recurrence was using denosumab previously. Well, the biological rationale and our expectations brought some benefits. But when we read the work, we see, well, it was a retrospective work. So, and like I said before, there was a control. There were many surgeons actually performing the surgeries. The patients were older, the ones that used denosumab, and they had tumors that had a distal extremity of the radial, that the recurrence is bigger, and the big number of those patients, they had a stage 3 probably. For many times, phenol was not used in patients that used denosumab because it was a uni-institutional evaluation or assessment. This work was really well, it was commented because it was a meta-analysis of study that showing that the denosumab usage was good for recurrence, no recurrences, but the ones that did denosumab, but they did an intra-lesional surgery, we saw that the diamond actually, it didn't show it was significant or meaningful, showing if the denosumab was good or bad. So how can we explain that? There are many studies, many trials, even Constantino Errani ones. The studies was retrospective. The cases were not randomized or standardized. The HR, it was 5.7 of Scott Cient. We saw that these studies, these trials, they were for patients that the selection for users of denosumab were the ones that had more recurrency, they had more bigger tumors, and the data were not sufficient, were not enough to evaluate the situation regarding recurrence. But not talking about denosumab and talking about another study now, the zoledronic acid. So denosumab versus zoledronic acid. So the zoledronic acid, actually, it was retracted because of ethical problems, so we don't have sufficient data for that. But the problem that use denosumab is that with the calcification of the tumor, we lose the lining of the tumor extension. So it's hard to choose, we talk about intralesional surgeries, and there is a data of some sort of malign transformation post denosumab, and we don't have chronic use of data in relation to this treatment that it could actually not be good in that. In the metastatic disease, we have a control. And speaking about our group experience, last year, we have 65 patients. We had 50 patients last year, but nowadays we have 65. So 62% of these patients were women. And the age group was from 21 to 40 years old, and it's around the knees. We had some rare cases about, distal femur and tibia, talus and tibia, but this is our casuistics. When we evaluate patients that had surgery, 56% they could, they underwent surgery, and 28 patients that had surgery done, they did Denosumab. 40 patients, 12 had a metastatic disease, and the relapse happened in 26%. 75% had like a pulse biopsy, and 63% had a complete pathological response with no visible disease. But even though they had that outcome, they had five of them, 26%, had a relapse after the surgical treatment. So another interesting data from our group was that the pathologist should be careful and understand that this was the image is post-denosumab, and it's because there are some orsosarcomas, and it has to be said to the pathologist that the patient's TCG, tumors of giant cells, and the level of general relapse was 32%. So, Becker, just very fast, I just want to show some cases, some pictures. A patient of female, she had a proximal tibia, she did denosumab, and the approach was intralesional, and she was treated, and she spent 2 years with no relapse, but then she had a little relapse in this little tip here, and to avoid a more radical treatment, we chose to restart the treatment, and then it was a complete good outcome. The patient had a very big injury. See here, lesion, very big. And then the response of denosumab, she had surgery. I mean, she underwent surgery because there was no other way. And today, she is very well adapted. She's doing very well. So these two, of course, are rare cases. And she had an orbit giant cells tumor. She had radiotherapy. We started with denosumab, and you see the tumor got so much better. She was really ashamed of going out of her house. She was always wearing dark sunglasses, and she's feeling much better now. And it's been 5 years already, the treatment. Speaking about our goals, I think we can, even though the data are still conflicting, but I think we can definitely modify the surgical treatment of our patients. We can definitely improve the symptoms, we reduce recurrence and control metastatic disease. About recurrence, we need to uniformize the treatment and try to choose better the treatment of our patients. And my conclusions are about giant cells tumors of bones is denosumab is a valid therapy. Yes, we can change the surgical plan. We can improve the quality of life of the patients. We can control the metastatic disease, but we still have many questions. Does this really reduce recurrence? What's the ideal dosage of neoadjuvant? In the advanced disease, local metastatic, what's the best way to do the treatment, and what are the surgical limitations post-denosumab? This is not a miracle. Sometimes it happens. This is a very recent case last year, end of last year. She's younger than 20. She's 19 years old. She has a huge tumor around her hip. She was always in bed. She was in the hospital, and she had a lot of pain, high doses of opioids. And then we started with denosumab, and she came back to the medical office after 3 months of denosumab. She was actually back to walking, and this wouldn't be possible if we didn't have a multidisciplinary team. This is pre-pandemic, right? Before the pandemic, everybody were there together, no masks. So these are the team. This is the team, especially for tumors of giant cells. So I'd like to say thank you. Thank you very much, Dr. Becker, for inviting me. And I'm here for answering the questions that you might have.
Obrigado, Felipe.
Thank you so much, Dr. Felipe. Great class. Great presentation. It's so good especially when talk about the treatment of Denosumab, I have some questions because we don't have a lot of time. But the question is, when we finish the treatment with Denosumab, when do you end the treatment? When is the end of the treatment with Denosumab? Well, we actually make an evaluation every 3 months for patients that are level 2 or 3, when we plan a treatment that is less morbid. After 3 or 4 months, we consider stopping the Denosumab. But of course, we have to see X-rays and everything. But I would say between 3 to 6 months, a good time for ending the treatment with the drug Denosumab. Elio Ishihara is asking if you had a sacral completely covered, by tumor of giant cells. Well, Denosumab continuously with evaluations of a reduction of the dosage, actually maybe with more intervals of application as the disease gets more stabilized. So I try to do an attack doses. Sometimes I go and move to like monthly applications because the toxicity is very high. But usually I go like every 2 months and every 3 months and maximum for 6 months. So I have 2 or 3 patients under this strategy right now. And in your protocol, do you use bisphosphonates? No, we don't. No, we don't. We do a periodical odontological evaluations, lab exams, lab tests, radiological tests every 3 months too, only with Denosumab. And the last question is, Marcelo, when he does the resection, what's the margin that he considers? Post Denosumab or the initial, like before that? I don't know. We should ask Dr. Ricardo, because honestly, I mean, it's hard because this other doctor told me it's hard. We don't know for sure. I mean, I'm not a surgeon, but you guys, surgeons, after Denosumab, maybe you can approach a few things that can make this niche of cells that still are capped there. But the last time I asked Dr. Marcelo, as a matter of fact, I believe, if I'm not mistaken, I think the intraoperative period, he makes some radiological analysis. I don't know if Marcelo can say something in this webinar, but I believe this would be what he would answer. Thank you so much, Dr. Felipe. It was such a pleasure having you here. Thank you. Thank you for the opportunity of speaking from the north of Brazil for you guys in the southern part of Brazil. Becker? I'd like to thank Dr. Felipe. So nice to share your outcomes, because you guys from the northeastern region of Brazil, it's so great. It was hard that we couldn't use this in the national casuistic, but anyway, thank you so much for a presentation, Felipe. So let's keep going. And I'd like to present the activities of Dr. Michelle Ghert. She's going to be talking about the prophylactic antibiotic regimens in tumor surgery, the PARITY trial or PARITY study. Nowadays, especially in musculoskeletal tumors, is great. I mean, this is such a reference. So Dr. Michelle, coming from the University of McMaster, University of Toronto. And so, Michelle, I guess the floor is yours. Are you ready?
I'm ready. Thank you. And can everybody see my screen?
Okay. Yes.
Great, thank you. And thank you, Dr. Becker, for the invitation. I'm very excited to talk to my friends in Brazil about the PARITY trial, where we are with the trial. We're very close to being able to present results, but I want to show you the experience of the trial, what the trial is, and where we are in the data analysis and when we're going to let you know the results. This was a really big study. We required quite a bit of funding. So I would like to acknowledge the Canadian Cancer Society, the Canadian Institutes of Health Research, the Canadian Orthopedic Foundation, the MSTS, OREF, Physician Services Incorporated, and the Silver Hearts Foundation. The objective of the PARITY trial was to determine whether a long duration or 5 days of post-operative antibiotics is more effective at decreasing the rate of a surgical site infection compared to short duration or 24 hours post-operative antibiotics for patients having surgical resection of a bone tumor of the femur or tibia and endoprosthetic reconstruction. This was a randomized study, international, multi-center, with a parallel arm design and randomization concealed allocation using a secure online platform, randomize.net. The outcomes were blinded, so there was a blinded adjudication committee of 4 orthopedic oncologists and 1 infectious disease consultant who looked at the cases that were determined to be infections by the treating surgeons and adjudicated blindly whether an infection did indeed occur or not. This was done on an online platform, Global Adjudicator. The study is triple blinded, meaning that patients, surgeons, and care providers, the data collectors, the outcome assessors, and the data analysts were all blinded to treatment allocation. The antibiotics were shrouded so that no one knew which arm the patients were allocated to. This is very, very important to reduce bias in clinical research. The interventions were antibiotic regimen 1, which was IV cefazolin or cefuroxime for 24 hours and 4 days of placebo, or intravenous cefazolin or cefuroxime for 5 days postoperatively. The patient population included patients with primary bone tumors or soft tissue sarcomas that invaded bone, or oligometastatic bone disease of the femur or tibia that underwent resection and endoprosthetic reconstruction. The primary outcome, the reason why we did the trial, was to determine the surgical site infection within 1 year after the date of surgery. A surgical site infection was classified according to the criteria established by the CDC. The study was managed centrally by the PARITY Method Center at the Center for Evidence-Based Orthopedics at McMaster in Hamilton, Ontario, Canada. There were many clinical sites that participated from 6 different continents. There were 55 clinical sites and 48 sites enrolled across 12 countries and 6 continents, and there were over 150 investigators. Enrollment started in January 2013 and was completed in October of 2019. This graph shows the monthly enrollment in blue, and you can see that overall there was an increase over time, but there were some months with a lot of enrollment and some with less. But the number of sites increased steadily, so we recruited more and more sites throughout the trial to participate. The country that enrolled the most patients was the United States, followed by Canada, then India, then Brazil. Brazil was 4th. However, the average site enrollment, so each site enrolled in India 39 patients on average per year, whereas in Canada it was 7.3 and Brazil was 3rd place with 4.5. So very good volume from our Brazilian sites. So this is where we are, and I need to explain to you that I cannot tell you the results of the trial because I remain blinded. In October 2019, as I mentioned, we completed enrollment. Then we completed follow-up 1 year later. We had quite a bit of time where we had to get all of the information from the sites to make sure that the data was clean. This was a very rigorous process, and that was completed in April. Data analysis is complete, and we are in the stage of manuscript preparation. The writing committee is meeting this week and will be unblinded. Therefore, there are some people that will know this week the results of this trial. However, the data is embargoed and they are sworn to secrecy until we present at the MSTS meeting in October with simultaneous publication in a top journal. So I'm going to show you what the data will look like without the actual data. And I apologize because this is anticlimactic, but I cannot present the data because I'm actually blinded to it and I don't know the results. There were 611 patients enrolled. Some were confirmed to be ineligible and they were excluded. We are going to report on the baseline characteristics of the patients: age, gender, race, location of tumor, comorbidities, and perioperative chemotherapy and radiation. We will also report the frequency of crossovers, meaning patients that were randomized to one allocation but switched over. We're also going to report the number of patients that left the hospital before 5 days, and therefore they did not receive the full protocol. This will be the primary outcome, and this is what everybody is waiting for. We are going to report the number of surgical site infections in each group and the hazard ratio to determine which is better and if there's a difference in preventing surgical site infection. We will do sensitivity analyses to make sure that we account for deaths and amputation as competing risk. We will also do a sensitivity analysis to adjust for clinical site, and also to determine if the per protocol analysis was similar to the intention to treat analysis. We will do subgroup analyses, but these are not powered to determine a difference. We will look at tumor type, tumor location, patient sex, age, or perioperative chemotherapy status to determine if these subgroups were different between infection versus no infection. We do have secondary outcomes, meaning that we are also interested in other outcomes other than infection, but again, we are not powered to determine a difference. These are exploratory outcomes. We're going to look at antibiotic-related complications, which is very important to determine, given that 5 days of antibiotics could be considered quite long. And it is important to understand if it increases antibiotic-related complications. We're going to report the unplanned reoperations in each group, as well as oncologic events. So this would be tumor recurrences in each group and the hazard ratio, as well as metastases and the hazard ratio. We're also going to report mortality to determine if there's a difference between groups. This will be the conclusion slide, so I'll just leave it at that. I would like to acknowledge all the PARITY investigators, particularly Ricardo at Porto Alegre and Andre Baptista and Juan Zimaraga in Sao Paulo. The Brazilian group contributed significantly to the study, and I'm very happy to collaborate with my friends in Brazil. Again, I would like to acknowledge the sponsors for this trial. Thank you.
Thank you, Michelle. Thank you very much for your presentation. I understand completely that you don't know the results and you can't present it because of disclosures. But I have, Edgard, is there any question from the audience?
No, nothing. No.
So I have one question for you. I would like you to talk about the difficulties in resolving data inconsistencies at the end of the study. Because as you can talk about the results, maybe you could tell us about the problems of the inconsistency, because I know it's a big problem and it gives a lot of work. So your data is huge.
Yes, as you can imagine, with over 600 patients and hundreds of data points for each patient across 12 countries, multiple languages, the quality of the studies that we run at McMaster they're held to a very, very high standard. And we are not accepting of data that's not consistent or up to date. And so, as you know, because you are a participating site, there are 4 levels of data analysis, but more data checking consistency. And so just before data analysis, we were in the 3rd level of data consistency checking. And so many sites had some data that wasn't clear, that maybe wasn't consistent with previous case report forms. Basically, we were looking for absolute perfection, that every data point was available and that every data point was consistent with everything else that was reported for the patient. So that caused a lot of pain during this winter, with us constantly haranguing all the sites to make sure that all their data is up to date. And we did the 1st level of data check and everybody thought they were done. Then we did the 2nd level, more intense. Everybody thought they were done. Then we did the 3rd level, and we started to get some frustration from sites saying that they already dealt with this issue, but we pushed ahead and we actually were able to stay on time and have all the data. The data quality is outstanding for this trial, and it has to be, because we're going to make treatment decisions based on the results.
Awesome. I understand, because you call me sometimes, Victoria, to call me about problems of inconsistency.
Calling, emailing, everybody. Yeah, but we did it.
Really outstanding. Okay. Edgard, do you have another question? Because I have one more.
Yeah, I would like to say thank you, Dr. Michel. It was a very nice year. All excited to see your results in October. I think it's very difficult to explain some details about the data collection, but how many people are enrolled to manage this data?
I have okay, so we have a data manager who I pay by the hour. So she manages other studies as well. So she's the prime data manager, and I had a team of 3 research assistants, research coordinators working to make sure the data is at the quality level that we need. So we had a team of probably 4 people full time.
How frequent is the Yes. How frequent is the contact with every site?
Probably, well, during the course of the trial, every 2 weeks, the site gets an email saying this data is good, this data we need updated. Every 2 weeks throughout the trial. But then at the end, so, starting January of this year, we probably contacted most of the sites every week. Ricardo can answer that.
Yeah, I can. The girls send me messages, SMS, send me emails, because it's really outstanding. So they need the quality of data. So I think maybe each 2 weeks, maybe they send me messages. And yeah, Michel, I'll play the devil's advocate here. Okay, I know you have to. I know how you have to follow the disclosure rules. But during the course of the study, did you notice the need for change in the prophylaxis of your patient?
Well, I was blinded to what they had, so I don't know. But I've always practiced with only 24 hours post-op. There were a few patients that declined the study that I just used 24 hours. I didn't notice anything different, but again, I'd say 90% of my patients during those 5 years were enrolled, and I was completely blinded. So I do know that, you know, because that we have lots of infections in our field, and I can tell you that is that we are plagued with infections, and you know, it's a big win if you go a year without an infection in these cases.
Yeah, you're right. Michelle, thank you very much for your presentation. We look forward to reading the PARITY study main article, the main paper. So yes. I hope to hear news very soon, because I'm gonna subscribe, register in MSTS.
Okay, yes, everybody needs to register. Register for MSTS, everybody, because that will be the first time we will be announcing. And again, I apologize, I couldn't do anything today, but I don't know the answer. So,
and congratulations for your president-elect. I know you're elected, but
yeah.
Thank you very much.
Brazilian Orthopedic Oncology. You can be our guest nation.
Great.
That would be
great. Awesome. Congratulations.
Okay.
Thank you very much. We're gonna move on now. Okay. Bye-bye. Thank you.
Yeah.
Michelle, we're gonna keep the translation to English if you need. Dr. Reynaldo will speak in English now if you want to keep. Okay. Feel free to do what you want.
Switch devices.
Yeah. Okay.
Thank you.
Awesome. Bye-bye.
Bye.
Então, pessoal, nós vamos seguir em frente com as atividades. O professor
Let's follow the activities. Professor Reynaldo will make his presentation now. Can we?
Eu acho que não sei se você está escutando, me desculpa, eu estava no inglês aqui. O professor Reynaldo Jesus-Garcia vai apresentar agora.
Professor Reynaldo Jesus-Garcia will talk about the challenges of the treatment of megaprostheses for musculoskeletal tumors. So, Professor Reynaldo, the floor is yours. Muito obrigada. Muito obrigada.
It's a real pleasure to stay here with you and so important speakers. And our question is, are we observing a decrease in the number of complications in bone tumor prosthesis? I'm not sure. So our team is all the people of Paulista School of Medicine, GRAC, and the people for the engineering that are my master students. And advances in the treatment of malignant bone tumors have allowed successful reconstruction of the long bones after tumor resection. The endoprostheses for the reconstruction involving joints were used in most of the tumor centers, and the modularity, improved design, bone fixation, quick return to function favor the endoprosthesis as a reconstructive option. The tumor prosthesis has been used since the 70s, and despite these 50 years of experience and improving of the prosthesis, we found a high rate of complications in this option of limb salvage. The most common prostheses are proximal humerus, proximal femur, distal femur, and proximal tibia. And to compare our data versus the literature and observe if we are improving the results in the reconstruction with tumor prosthesis, we did a study. It was a retrospective study from January 2008 to December 2013. So at least 5 years of follow-up of all patients, 69 patients, 12 to 24 years, 38 females and 31 males, and the diagnosis was osteosarcoma, chondro, and Ewing. Now look at that. Look at the diagnosed number of patients, osteosarcoma, Ewing, and chondrosarcoma. And the number of prostheses, 15 proximal humerus, 11 proximal femur, 24 distal femur, and 19 proximal tibia. And look the complications. We had in the proximal humerus 8 complications, proximal femur 5, distal femur 17, and proximal tibia 13. And 43, but we have patients with more than one complication in each group. Yes, let me move my, okay. Okay. And look at the complications. And when we study the proximal humerus, we have most of the complications were soft tissue failures and other not so frequent complications. In the proximal femur, most of our complications, 100%, were the soft tissues failures. The distal femur, we had all types of complications. Proximal tibia, most of them was soft tissue failure, basically the loosening of the patellar tendon. And in the media, look the medium of this all sides, okay? Without distal femur, proximal tibia, and all sides. And after these results, we would like to know how about the complications in literature? And we review a lot of patients that just studied complications. And we have our statistic and some of the complications in literature, and from 1987 to our days. And look that there are many cases of complications. Look at that publication of Chow and Singh, aseptic loosening, a lot of aseptic loosening, and other from Jace, other paper from Jace in 2008 with a lot of aseptic loosening. And when we study infection, all the publications talks about a lot of complications in infections. This paper of Jace, 25-28% of complications. Another paper from Grimmer from Birmingham, look at a high rate of infection. And if you study structural failure, we can say that the structural failures are decreasing with the time, but we have in all publications problems with the construction of the prosthesis. And local tumor recurrence also around 10%, the maximum local recurrence rate, and we have around 4 to 5% of local recurrence rate in all papers. And if we study, we see that even in the from 1987 to nowadays, we have the same complications. It's the paper of Anderson that they talk about the 5 main complications of the prosthesis. And what is our major problem? To understand when pain, radiographic aspects, mechanical failures, decrease of the bone quality, infection, local recurrence, non-satisfactory function, and clinical outcomes are indicating the revision of the prosthesis. It's our main concern because it's difficult to do the revision of the prosthesis. The surgeon has to decide between revision of the prosthesis and an amputation. And we have to decide with the maintenance of the prosthesis, with changing the prosthesis or the removal of the prosthesis and use a spacer. It's very difficult. When we have a patient like this, 24 years after post-osteosarcoma, and we can see this, it's no doubt about review the prosthesis. When you have local recurrence, no doubt about review. When we have a dislocation like this, or when we have, for example, a dislocation like this, patient to 2020, it's a 60-year-old lung cancer patient, a proximal femur, it's a lung cancer, and the patient had a dislocation. the patient was in Minas Gerais, and Dr. Ricardo Horta called me, your patient is with a dislocation, and he could, without no problem, to correct the dislocation, the patient is okay. But we don't have doubts when we have patients like this, or when we have the mechanical failure like this, after 11 years, the releasing of the head of the femur, or broken prostheses like this, mechanical failures, and no doubts. But sometimes the problem is this. We have a prosthesis, 2009, look the prosthesis, looks like, okay, no problem, it's the post-operative, immediate post-operative, and the patient, after 10 months, starts to complain some pain. It's difficult to understand. Scintillography show a hot spot here, but it's difficult to say, oh, it's the prosthesis is released. We have to revisit this process now. This is difficult, 10 months after the surgery. When is the best time? Look at that. After 11/20/10 and May, 6 months after, looks like that they improved. It looks better. And we can see here, 1 year and 6 months. And after, right now, we can say, okay, it's releasing. But maybe infection, it's very difficult to decide. And why we have so difficult decision? Because the revision surgery is difficult and unpredictable. Like this, we remove the prosthesis and we found this kind of the femur after removal of the prosthesis. It's very difficult. Look at that. We have to be prepared to do the revisions. This is a patient with an undifferentiated sarcoma, high-grade sarcoma, after chemotherapy, after radiation therapy, after limb perfusion. And look at that, the conditions of the skin over the tibia. It's very hard to do a surgery, to do a prosthesis like this. We have to remove a lot of skin, and we have to do it, and we have to, in block, resect everything. And we know that we have to cover very good. We have to cover this prosthesis very well, very well. And we have to be prepared when we go to a surgery like this to do like this, a skin graft. Look at that, a very large graft. And we can see that the condition of the graft, we can say that, oh, okay, maybe it will be okay. But it's difficult because after 2 or 3 hours of surgery, we have to start the plastic reconstruction and the microsurgical reconstruction. And we have to be prepared to skin grafts. And it's very difficult. It's a hard surgery. It's a hard time we have to do with this. Look at that. Another patient, 2013. We can say that, no, that's okay. That's a good cementation, the plug, but the cement went across the plug, but that's okay. And 2016, 3 years after, everything looks okay. And we have some stress shield here. And after that, 2018, everything is okay, looks like okay. But we can see here that the migration of the stem, it's very common, this 2019, 4 years after the first surgery. And look at that. So we have like no wall in the, look at that, no wall in the cortical bone. It's very difficult to do a revision like this. It's hard to remove the cement. It's our big problem. Sometimes I don't know the name, canaleta, a hole here to remove this cement, to open the femur. And we try to use not cemented, uncemented prostheses like this, and block the prosthesis. And to use long stents, like in this case. Look at the prosthesis. So, and we have to close this sometimes with cement or sometimes with nothing. We have to pass the fracture and the cortical problem. We have to use, and we have to try to use a curved stem. Man, it looks like better. And if possible, if we have some cortical, we can block it and we can use this kind of prosthesis. And this is the result. Look at that, 2016. It's the patient had a chondrosarcoma of the proximal femur, grade 2 chondrosarcoma, grade 2 to 3, and it was a removal, and everything is okay. We use a partial prosthesis here, and look at that, 2018, and we don't know why it happened. 2018, and that everything looks like 2018, but we start to see the releasing of the prosthesis, and the patient starts to look at that. 2000, in 2 years, a little bit more than 1 year and 6 months, we can say the moving, the releasing of the prosthesis and the moving and the fracture. So in this case, we have to decide and we have to do the revision. It's very difficult to do this kind of revision because we have a lot of cement. And look in this case, the cement is enlarged here. It's very difficult to remove the cement by this part, by the proximal femur and the prosthesis. And what we have, look in 2006, 5 years later, the moving of the stem. And we have to go to the surgery with everything possible. It's not only partial hips, but total hips and several sizes of stents and diameter and such. Look at that. It's always the same, when we see the release, look at the patient has, and when we remove it, sometimes the cement came, but just part of the cement came with the prosthesis. Look at that, the cement here coming with the prosthesis. And we have to go back and to try to remove, and a lot of instruments. And sometimes we have to open a window. I'm not afraid in open a window. It's much better to open a can or to open a window. It's much better. Yeah. And look at that. We have to pass through the window. We have to extend the stem and to use large stems. So, and sometimes we try to fix. In this case, for example, the thinning, the cortical were very thin, and I'm not sure to leave just the screws blocking the prosthesis. And when we have infection, the problem is much better because we have the releasing of the prosthesis. I always try to keep the lengthening of the gap, and I use a wire in the bone to reconstruct after the removal of the prosthesis. Look at that. Look at the prosthesis totally losing in the femur. So you can say, look at that. And unfortunately, just a little bit of cement in this case. It's the problem because we have to try to remove the cement, but it's very difficult. We have a large distance between the opening, the window and so in these cases, I always try to open windows distally and to try to remove all the cement and the reconstruction with a spacer. And sometimes we go to this operating room and we have a erythromycin cement. We prefer gentamicin, but look at that, the reconstruction, go to the surgeon, always with this kind of wires to cables to reconstruct. And when we finish the surgery, the windows, broken bone, metallosis, and a lot of problems in this revision. And we have to do the complete removal of the cement from the femoral canal, and the same with the tibial canal. And the window, look at the diameter. Sometimes the diameter is 25 millimeters, so it's impossible to fix without cement a stem in this case. And look at that, we keep the lengthening of the bone. This is the very important, so we can finish this. The possibility of blocking the prosthesis and to use a curved stem, sometimes it's very good. A big team, experts, all experts, also it's important to go to this kind of surgery always prepared. Look at the window here, and sometimes a lot of problem. We have to cover, we have to always close and cover the distal femur. Proximal tibia, we always do the malware technique with the cover with a graft, but the distal femur is not necessary. And we have here the reconstruction and the fixation. So when we go to a surgery, it's very important for each patient understand that the tumor endoprosthesis is unconventional. It's very important. It's difficult to predict the rate of successful results. I'm very sad about the results of my prosthesis. The prosthesis survival without revision, maximum 10 years. It's very good when we get 10 years. Chance of infection, greater than 10%. The patient goes to chemotherapy and the patients are immunosuppressed. The chance of local recurrence, around 10%. The chance of shortening. The chance of surgical scar dehiscence. Sometimes after 15, 20 days, we start the dehiscence of the suture. Joint function is partial, and the change of the prosthesis dislocation. So we always do a very detailed, informed consent, and the patient sign, and I immediately send to the patient by email or WhatsApp. So I'm sure that they receive the informed consent. For this reason, we are trying to apply a complication score that help us to decide when pain, infection, local recurrence, mechanical failures, evident signs of loosening, and signs are indication of to do the revision of the prosthesis. So we try to use this complication custom-made prosthesis score. So when we have pain in this situation, when we have major signs of loosening, bone fracture or dislocation, when we have major mechanical failure prosthesis, when you have imminent or present stem migration or limited run of motion, minus than 10%, sometimes we see this, and deep infection, recurrent, now new local recurrence, we have to do immediate revision of the prosthesis. I think it's the most important message to you. And our conclusion is, are we observing a decrease in the number of complications in bone and tumor prosthesis? No, we are not. We are not. It's a difficult surgery. If you do a surgery, make sure, you have to be sure that you can revise the prosthesis. You have to be sure that your hospital has everything we need to do the revision. Several prostheses, large stands, curved stands, all the instruments to remove the cement, and everything we need. And the patient has to understand that it's a limb salvage. It's a limb salvage. It's a luck of the patient when we don't have to remove the prosthesis and revise the prosthesis after 10 years. Okay, so it's it's my opinion about the prosthesis. Thank you. Thank you very much for the opportunity.
Muito obrigado, Reynaldo. Brilhante aula. Eu estou checando aqui, ainda não recebemos.
Thank you so much, Dr. Reynaldo. We don't have any new questions from the audience, but I have many questions to ask you. I know it's because you work with prostheses, right? That's why you have many questions. Is that right? Yeah, that's right. That is right. Becker. I don't know if maybe Reynaldo, yeah, maybe Reynaldo should, yes. All right, so he's in Portuguese now. So, yeah. Do you have complications of knee luxation? Do you have that, Paddle? Well, I don't know if you noticed, we tried to make a revision though, and we really had a friend, you know, he put many anchors in the knee to do the revision to try to keep it, the knee, but actually we had to do a denervation of that knee because the patient had a lot of pain. And then we did a denervation of the knee, but it's a very big complication. Of course, I didn't revise many cases, but you know, I just showed you some. But we had, especially the tibia prostheses, and then we had many also patella prostheses going on. But it's hard. And I'd like to ask you, when you do infection revision, do you do in 1 or 2 times? I mean, 2 times, yeah. 2 turns, revisions like that. It's not good to make a revision in like an only time. We do it in 2 turns, and we use the best cement that has the best antibiotic too. And we ask for the participation of people from the infectology department. And then we've been doing, sometimes we do vancomycin and gentamicin. I went to a public hospital once, and then they had that cement with erythromycin, and our colleague infectologist, Dr. Mauro, said he got very concerned if they only had that erythromycin, because in cases like that, we have to use vancomycin, but sometimes they don't have it in public hospitals. I do it also in 2 turns, and I use stems, curved stems, and so I use a proximal one and a distal one, and I try to fixate that, but I don't try to make the cement not enter much in the proximal channel. So sometimes you are so well cemented that you have to do that in that bone. We have some articles in the journal, the Brazilian Journal of Orthopedics, speaking about knee infection in prostheses of knees. I mean, the results are many. I mean, sometimes it works, sometimes it doesn't work. I have an impression that the prostheses are not doing very well. When I see a patient with prostheses, they have an appointment, you know, I go, well, I have to see this patient thinking, oh my God, probably there's an infection, probably there's a problem, because it's good to do, you know, those biological surgeries and so on. But when you have to put a prosthesis, I mean, it's big. So it usually goes wrong. Thank you, Reynaldo. Becker, would you like to make a comment? Actually, I'd like to ask you, Dr. Reynaldo, when I came back from my formation and I was traveling abroad, in 2010, I started using some malware. So sometimes you have problems in soft tissues, right? Because there's a claudications and so on. What do you use as a strategy? I use malware. What's your strategy? In humerus, in proximal humerus, we practically use 100% we do Malice web. So I do it, I grip the web, I mean that screen, and then that net, I'm sorry. So it's something that, because we always had the patients with that ugly prosthesis, you know, that humerus, very ugly. In proximal femur, though, we are not using that net. I always do that Malix net. I always have that in the surgery room, but sometimes we can't remove a tendon as close as we'd like to, you know, or taking a tip of a bone or part of a tendon. So sometimes you only have the muscle going on there, especially these big tumors, right? Where you have to make a extra resection, and you do it far from the major trochanter. So I try to make a reconstruction with prostheses, but these are not being well, they're not going well. So the technique, I mean, for femur is not so good. So I did the revision of a prosthesis, and it's a prosthesis that I did the review, and I put that net, and I go, I don't know what to do here. I don't know how to start, because the patient had an atrophy, so it was really bad. So if primarily when you do that, I think it's a spectacular.
Algum acetábulo tripolar ou não?
Have you been using any tripolar prosthesis? No, only bipolar. What's tripolar? It's total. And you have two joints, you know, to actually improve the range. Oh, no, I haven't been using it. As a routine, we've been using the bipolar for teenagers, and then we really do that. And for metastases, I do that bipolar all the time. And it's really good, you know. It works very well, actually.
Renato, mais duas perguntinhas.
Only two more questions. Do you use patella in your prosthesis? And if the stems, do you use cemented or not cemented? Patella. We have an expert in knee in our group. He does knee, which is Dr. Marcelo Petrini. He does knee surgery and tumor surgery. I always ask him, should we change or should we not exchange? We came to the conclusion that it's good to exchange it, because you have a teenager, you know, and we've been actually exchanging that for sure as a routine, because Marcelo likes that. He feels safer. But in patients that we don't do that, we don't do because I mean, we kind of get lazy, but I think the ideal is to do it. The big majority is we do it. The prosthesis is that we've been trying to do prosthesis non-cemented. The stem has to be calibrated and curved. So it's hard to do that because the flexible stem doesn't do that, and we don't have a lot of support points. Sometimes we do it and we go, this is not so good, it's rotating, so then we don't cement it, and it's not ideal, because then we go to the surgery with a, it's good for ingrowth, and in these cases, changing the alternatives and changing the tactics at the time of the surgery, we cement it. We know that it's not appropriate, but we do that. Sometimes we are scared just to leave that. We go, this is not going to be firm enough. But in revisions, we do that because the channel is better. But we don't have something that is like press fit. You know what I mean? So it's hard to block it. So, but I've been, you know, we've been trying because the concept keeps changing. You know, I like to read about complications of prosthesis, and it's worldwide, you know, so it depends.
Muito obrigado.
Thank you. Thank you so much, doctor. We're together, right? We are together, as a matter of fact.
Tem que achar todas as soluções para complicação.
So I have to find all the solutions for prosthesis complications. I'm pessimistic, right? Well, I mean, of course, they have improved already, but I try to fix that, the stem very well in order to make it very firm. Because in some cases, you don't have to make a revision, you know, because sometimes it's released, you know, but I think the biggest problem of the prosthesis is to remove the stem that it's cemented before, and that's hard because you lose bone storage. We know, because when the prosthesis, when the stem is very firm, the bone is good. I mean, you have a cortical that is very thin because all the charge is stolen by the prosthesis, you know, and it brings problems. But it seems to me that we are tending to do prosthesis with no cement. During some years, we did that. Apatita, we did that because the hydroxyapatita was not so good, but we saw, especially the English ones, they have the hydroxyapatita, which is polar. There's a color to do the boning growth, you know. I like that prosthesis, because the way of applying that is nice, you know. So we actually mastered that technology. I have the impression that this color of hydroxyapatita can make a difference, especially in the cortex, because then it's not nice to see a prosthesis, and then you see that in tibia it goes well, because I have been doing partial changes of tibia. And when you put a total, if you change the partial prosthesis for total in tibia, in femur, no. In femur, don't. Yeah, all right. Well, because, you know, you're not going to put a straight stem in a curved femur, right? Thank you so much. Becker, would like to make any final comment? I'd like to thank Reynaldo. Excellent presentation. Because we also, of course, the audience would like to ask many questions, but thank you so much, Dr. Reynaldo. Thanks very much. I'd like to thank the other speakers, Dr. Michele, she left already, and Dr. Felipe Marinho too. I'd like to say that the next webinar is going to be August 14th. So the colleagues, we're going to have Dr. João Paulo Fonseca de Freitas from Portugal, from Coimbra. He's going to talk about endoprosthesis, not only in tumors, but in salvage too. We're going to have an activity with Dr. Rodrigo Munhoz. He's the clinical oncologist. He's going to be talking about tenosynovial cells. And Dr. Jessen will talk about megaprosthesis around the knee. So basically we have this and Edgard, I think you can wrap up the activity, please. So I'd like to thank the presence of all of you and the patience of you, you know, watching us. I mean, one more event, one important ABOO, and I'm sure that we all learned a lot with our speakers. And I'd like to meet you on August 14th. So thank you so much. Thank you very much, everyone.